be Controversies in advanced endoscopy, mainly review abstracts for DW. We have two speakers. Our first is one of our guest speakers, Dr. Sachin Wani, Associate Professor of Medicine at the University of Colorado, and also one of the experts in the U.S. on Barrett's esophagus, and he'll give us a talk later on about that. So Sachin, oh, there you are, okay.
Good afternoon, everyone. I want to start off by thanking Laith and all the course directors for this kind invitation. So my task, along with Simon, is to really review some of the recent abstracts in advanced endoscopy presented at this year's DDW, and my focus will be on abstracts related to endoscopic ultrasound. All right, so the first topic that I'm going to address as it relates to EUS is to really try and answer this basic question: how should you be sampling patients with pancreatic masses or lymph nodes, and whether you should be using a fine needle biopsy needle, or whether you should be using a 22 gauge needle, a 19 gauge needle. I'm going to tie this up with the recently established quality indicators in endoscopic ultrasound, and hopefully, at least for the endosonographers in the audience, provide a pragmatic approach to sampling pancreatic masses. I'm also going to talk to you a little bit about the advances with regards to management of patients with pancreatic cysts. We know that this is a commonly seen condition, a common indication for us to perform endoscopic ultrasound, and I'll share some of the recent advances in interventional EUS as well. EUS-guided tissue acquisition, as we all know, whether it's done by EUS-FNA or fine needle biopsy, is really one of the most important steps in the diagnosis of GI and non-GI malignancies, and several non-malignant processes as well. Obtaining an adequate sample, arriving at an accurate diagnosis, i.e. avoiding false negative diagnosis, and ultimately improving patient outcomes. These are all fundamental endpoints of EUS-guided tissue acquisition. For anyone who is critically evaluating this field, or the literature published in the field of endoscopic ultrasound-guided tissue acquisition, you need to be familiar with these definitions that we use frequently in our studies. Specimen adequacy is the percentage of lesions sampled in which the obtained material is representative of the target site and is sufficient for diagnosis. The diagnostic yield is the percentage of lesions sampled for which a tissue diagnosis is obtained. Accuracy, which I think is one of the most important endpoints for any technique during EUS, is actually the percentage of lesions sampled that corresponds to the final diagnosis. And this is really based on your final result on EUS, the surgical pathology, and at least a follow-up of 12 months after the procedure. Core specimen, something that's really been a hot topic in EUS, is defined by the presence of a tissue sample that allows for histologic and tissue architectural assessment. Now, the last time I actually looked at this topic, there were at least 16 different variables that may or may not impact our ability to make an accurate diagnosis during EUS-guided tissue acquisition. The factors range from your technique during EUS, whether you use suction or not, whether you use a stylet, whether you use the fanning technique, the number of passes that you obtain during the procedure. The needle type is also an important variable that has been extensively investigated, whether you use a FNA or a FNB needle, what the needle gauge is. Something that's not been adequately studied, at least in the field of EUS, is the training and the competency level of the endosonographer and our cytopathologist. I think this really plays an important aspect in our ability to manage patients appropriately. At a center level, I think it's important to understand whether you have an on-site cytopathologist available when you do EUS and what your center volume for EUS is as well. So these are all important variables that you should be aware of. As I mentioned to you, there's been this really a big push to move away from fine needle aspiration needles to FNB needles or fine needle biopsy needles. And I will submit to you, there are certain advantages with the use of FNB needles. You get larger specimens when you use these needles. There is a potential for improving the diagnostic yield, especially for non-pancreatic lesions and in cases where you've got a non-diagnostic sample when you've used a FNA needle, or what is called as the salvage technique. Clearly, when you get these larger specimens, you can look at the architecture. This plays an important role in evaluating certain disease states, such as autoimmune pancreatitis, lymphoma, metastases, GI stromal tumors, and it has the potential for obviating the need for an on-site cytopathologist. This really plays an important role in personalized medicine, at least at our site at the University of Colorado. We are routinely using FNB needles, not because I feel that these are superior to FNA needles, but because all our oncologic-related trials and protocols require us to use FNB needles for specimen collection. So we decided to put all of this together in a systematic review and a network meta-analysis, not to be self-serving with the study that we presented at DDW, but we know that these are all the different types of FNB needles that have been described. There's the fork-shaped tip, the reverse bevel, the anterograde core type, and the Franzine tip type of FNB needle. In this systematic review and meta-analysis, we really wanted to compare the diagnostic performance of all these different FNB needles with FNA needles and compare the different needle gauges. Our secondary outcome was sample adequacy, core procurement rate, and the number of needle passes. We assess the quality of evidence using the grade methodology, and at least for the trainees in the audience, I think it's important to understand that these pairwise and network meta-analyses really help us inform comparative effectiveness analyses of multiple interventions and synthesize evidence across multiple randomized controlled trials. We know how difficult it is to conduct these RCTs to try and answer each and every question in the field. So this was our clinical question in patients with pancreatic masses, which is the best approach to get an accurate diagnosis? And we compared all these different factors with each other. Our primary outcome was the diagnostic accuracy. This is just a graphical representation of what a network meta-analysis looks like. The size of the node and the edges actually represent the weight of the studies and the number of studies actually comparing these two different variables. This is the final result slide of this network meta-analysis. The take-home messages, it really makes no difference what technique you use in your practice, as long as you practice the appropriate methods of identifying the lesion and getting your lesion well sampled by any needle, whether it's a 22 gauge, a 19 gauge, or 25 gauge. There's really no difference in your accuracy rates between these three different types of needles. If you believe that these results were really altered by the presence or absence of an on-site cytopathologist, we analyzed our data based on that factor. And again, when you take out the absence of an on-site cytopathologist, our results were the same. Our results were actually consistent with what the ESGE recommends, which is sampling of pancreatic masses and lymph nodes can be performed either with a 22 gauge needle or a 25 gauge needle, and FNA and FNB needles are equally recommended. I will spend a couple of minutes, at least for the endosonographers in the audience, to recognize that the ASGE and ACG have established quality indicators for endoscopic ultrasound. These are indicators that you should be aware of, and your practice should meet these established benchmarks. I'll just highlight the three main priority quality indicators for endoscopic ultrasound. These include the fact that you should be staging all GI cancers using the AJCC or the TNM classification system. When you sample pancreatic masses, you should be measuring your diagnostic yield and sensitivity. And finally, you should be monitoring your adverse event rates in your practice. So this is just a pragmatic approach to sampling patients with pancreatic masses. The first thing you want to do once you do identify a solid pancreatic mass, you should stage this using the TNM classification system. Recall that this is a quality indicator for us as endosonographers. What you do next with regards to EUS-guided tissue acquisition is really dependent on whether you have an on-site cytopathologist or not. If you do, you should really base the number of passes you obtain based on the feedback that you get from your cytopathologist. If you continuously get inadequate samples after you've done 4 passes for lesions that are greater than 2 centimeters or 6 passes for lesions that are less than 2 centimeters in size, you should consider an alternative approach to sampling. Switch maybe to a FNB needle. On the other hand, if you make the diagnosis, that's great. You should feel good about this, and then you move on. On the other hand, if you don't have an on-site cytopathologist, the number of passes that you obtain is really based on the size of the lesion. For lesions that are greater than 2 centimeters, you should perform a minimum of 4 passes. For lesions that are less than 2 centimeters, you should perform a minimum of 6 passes. And I'm really referring to your practice using FNA needles. Recognize the 2 main quality indicators when you're sampling pancreatic masses: your diagnostic yield and sensitivity. I'm now going to switch gears and talk a little bit about how we approach management of patients with pancreatic cysts. We all recognize that these are extremely common and they can often pose a management dilemma. This was an international multi-center study, and the investigators actually developed a comprehensive test. They call it the CompCyst. These are results that were presented at DDW this year, and they combined clinical, imaging, and molecular biomarkers. The molecular biomarkers they included were mutations in 11 genes that were associated with specific cysts, loss of heterozygosity, aneuploidy, CEA, and VEGF. And using this panel, what they showed us was that the clinical management can be significantly altered. If you use this in your practice, you would potentially spare more than 50% of your patients from unnecessary surgeries. Now, I will tell you that this is really just based on 862 cysts, where they split up the cysts into a testing phase and a validation phase. So there's several things that still need to be done before you start using this method of actually risk stratifying patients with pancreatic cysts. First and foremost, I think this needs to be confirmed in a prospective trial outside of this testing and validation cohort. And of course, we need to evaluate the cost effectiveness of such an approach to evaluating pancreatic cysts. Another approach that really has been investigated fairly extensively now over the last few years is how we can improve our cytologic yield when we sample pancreatic cysts. I think all of us recognize that the overall yield of fine needle aspiration of pancreatic fluid is really suboptimal with regards to the cytologic accuracy. So what investigators have done is really try to use imaging modalities by going into the cyst by using the needle-based confocal laser endomicroscopy technique, or actually passing a microforceps into the cyst by puncturing the cyst using a 19-gauge needle. This was a retrospective study, and they really compared the diagnostic outcomes and changes in clinical management using these novel techniques in addition to your EUS FNA. What the investigators showed us was that the diagnostic yield for combined testing was higher than EUS FNA cytology alone. Not surprising to many of us who do EUS, but what this study really showed was when you used these combination approach, or what we call as a multimodality approach for evaluating pancreatic cysts, you can change the clinical management in up to 40% of patients. It really did not impact the number of patients that had surgical evaluation, but what it did was it changed the management with regards to surveillance of these patients with pancreatic cysts, potentially avoiding all these multiple CT scans and MRIs, potentially taking patients off any surveillance protocol. So from that standpoint, I think this is a major change in the management of pancreatic cysts. Again, just like the previous trial, we need prospective data on evaluating these modalities for patients with pancreatic cysts. I'm going to spend a few minutes talking about interventional endoscopic ultrasound. We've seen over the past few years that we've really had numerous advances in this field. We're really shifting the needle away from just using endoscopic ultrasound for staging of cancer and making a diagnosis of malignancy. We're now moving to potentially disruptive techniques and technology, and interventionally, US is really increasingly being used as an alternative to interventional radiologic procedures or even surgery. Now, this is just my approach. This is how I think of interventional endoscopy or the procedures that we do with this platform. It's based on the overall complexity and the adverse events related to these procedures. Right at the top is, of course, your bread and butter EUS staging and diagnosis performed during EUS. The next level is EUS-guided tissue acquisition, whether you use FNA needles or fine needle biopsy needles. The next step is EUS-guided celiac plexus blocks or celiac plexus neurolysis, placing fiducial markers into lesions, and EUS-guided cyst ablation. The next level of complexity really addresses drainage of pancreatic fluid collections, whether they're pseudocysts or walled-off pancreatic necrosis. At the next level is actual drainage of the bile duct and the pancreatic duct. And then finally, EUS-guided vascular therapy. This classification has not been endorsed by any of our GI societies, but this is just my way of approaching these interventional EUS procedures and how we train our advanced endoscopy fellows. I will tell you that none of our advanced endoscopy fellows actually gain competence in any of these interventional endoscopic ultrasound procedures. I'm going to talk about EUS-guided gallbladder drainage, and this really has been, again, a major change in the way we manage these really sick patients who are not candidates for undergoing a surgical cholecystectomy. Up until now, we've had observational data, mainly from multi-center retrospective studies, that this is feasible. You can actually achieve a high level of clinical and technical success by draining the gallbladder using an EUS-guided approach. Here's a patient that was cirrhotic, too sick to undergo a surgical procedure, a cholecystectomy at the University of Colorado, and was actually drained using an EUS-guided approach. The whole concept is getting the gallbladder in view in the 6 o'clock position and using a cautery-enhanced lumen-opposing metallic stent that gets placed into the gallbladder. You always have the option of bringing the patients back and actually taking care of the stones within the gallbladder. This patient, all we really did was placed the stent, and this patient did fine after placement of this lumen-opposing metallic stent. So again, the limitation was retrospective study. There's always a risk of selection bias from all these multi-center retrospective studies that get published in the field of interventional endoscopy. So the next study that I'm going to talk to you about is, again, a major advancement in our field. This was a randomized controlled trial presented at DDW this year, where they included all patients with acute cholecystitis too sick to undergo surgery. Patients were recruited from high-volume institutions, 5 high-volume institutions, and again, they included only patients who were not candidates for cholecystectomy. You can ask, well, who made that decision? That decision was really made by anesthesiologists and the surgeons who participated in this study. Their primary outcome was the 1-year mortality and morbidity rate after undergoing this procedure. The secondary outcomes were technical and clinical success, unplanned readmissions, reintervention, and mortality. This is just your classic table 1 showing that the two groups were well matched with regards to demographics, the size of gallstones, and the total amount of procedure time between the two groups was comparable as well. These are the primary results. These investigators actually met their primary outcome, and they showed us that the 30-day adverse events and 1-year adverse event rates was significantly lower in patients undergoing these procedures by a EUS-guided gallbladder drainage. Now, obviously, there are limitations of this study as well. It does not assess the role of ERCP-guided transpapillary cystic duct stent placement. One thing that I feel very strongly about these randomized controlled trials, at least in interventional endoscopy, is to really ensure that your outcomes are being assessed in a blinded fashion. And I could not tell from this study, at least at the present time, the way it's published in an abstract form, whether that was performed or not. Obviously, the manuscript will provide some insight into this important way of assessing randomized controlled trials. We also saw a few abstracts that were presented at DDW, and I'll just give you the cliff notes. The bottom line for these two abstracts was that it is safe to actually drain early postoperative fluid collections or early peripancreatic fluid collections. The conventional wisdom is that you should wait for at least 4 weeks until you have a nice wall around these fluid collections and then perform EUS-guided drainage. These investigators from the Mayo Clinic, and there was another study from South Korea, showed us that you can actually drain these fairly soon, below this 4-week threshold. Two other abstracts that were fairly intriguing to me. One actually addressed sampling portal veins during EUS in patients with pancreatic or biliary cancers, collecting tumor cells, the presence or absence of tumor cells, which may actually provide some prognostic information in patients with these cancers. Preliminary results of a randomized controlled trial showed us that patients who undergo radiofrequency ablation of pancreatic masses in addition to chemotherapy may actually require a lower dose of morphine compared to patients undergoing chemotherapy alone. So again, our role may actually expand in management of patients with pancreatic cancer beyond just making a diagnosis or putting in a stent in the bile duct. I'm going to end by just pontificating a little bit about how you could potentially incorporate therapeutic EUS or interventional EUS in your clinical practice. One of the things that I feel very strongly about is to really obtain a good informed consent, discuss the risks, benefits, indications, and how you plan to manage adverse events related to your procedure. It's really important for us to consider what the impact of our interventional EUS procedure is going to be on definitive surgery. This really comes down to whether you're managing a patient with malignant disorders or a benign condition. Does the patient have pancreatic or biliary ductal dilation? Does your patient have resectable or unresectable cancer? This really has to be done in a multidisciplinary fashion. You need to have good backup from your surgeons and interventional radiology if you're going to embark on any of these high-risk procedures. If you're just starting off, you've got to do these procedures under the guidance of experienced mentors. Make sure that you have all the equipment required for these procedures, and at the very least, you should maintain a log and follow up on the outcomes of these patients. I'm going to stop here and now hand it over to Simon to talk about the abstracts on ERCP. Thank you so much for your attention.